once you have finished radiation, whether it's whole brain or it's SRS, what is the time frame to when you do an MRI to look at what the radiation did?
So, Leanne, that's a great question. And there's a number of factors to consider. So I think if people are following guideline-based care, such as NCCN guidelines, a consideration would be to do a repeat brain MRI in about 3 months after whole brain, or potentially 2 months after stereotactic radiation, with the shorter time interval for stereotactic radiation being out of concern for the development of new brain metastases. But I think, doctors and nurses and patients and therapists and other people who manage brain metastases often recognize that one patient is so different from another. So you have patients that have rapidly progressive brain metastases, and they're not going to jive with a 2 or 3 month follow-up. They may need a 1 month follow-up. You have patients who've had a long track record of having smoldering brain metastases, meaning things barely change with time. And even if we end up using radiation, we might not do the next scan for 4 months after, because we really understand the trajectory of the disease and what we would expect. So it varies a lot from patient. Other factors to consider as well. But I think the most kind of standard would be about a couple months after stereotactic radiation, and about 2 or maybe 3 months after.
Gotcha. I think that has that sticks with the theme of brain metastasis, that it depends. That seems to be the overarching theme that connects all answers and about treatment and radiation. Is it really is an individual thing. Is there any problem to screening too soon?
Doing a scan a little bit too early. So
Yeah.
it's a great question, and largely the answer is no. There's some cost potentially to patients in the system. There's the inconvenience of the scan. And patients with kidney function is, optimal, or if they're, have stage 3, 4, 5 disease. The contrast that we use with the MRI, the gadolinium, poses some risk, not a lot of risk, but a small amount of risk. And then a recent discovery is that some of this contrast isn't being entirely cleared by the body in patients, but the ramifications of what does that actually mean on a day-to-day level remain highly unclear. So we have not been telling patients that they should refrain from scans for any of those reasons. If they have, for example, really poor kidney function, we will maybe do a scan without gadolinium. But largely, apart from those minor issues, doing a scan too soon, usually there's not a lot of downside.
Okay. So when you've completed radiation and you do the scan, what are you looking for? What is the goal of radiation therapy? What are you hoping to see? Is there something that you hope to see on the scan?
It's another really helpful point to talk about. And radiation is different drug-based therapy in terms of what we expect to see in the scan. I think with most drug-based therapy, whether it's chemo or targeted therapy or HER2-directed therapy, hormonal therapy, you generally would assume that when things shrink, it's optimal, and when things grow, it's not. With radiation, it doesn't really work that way all the time. Initially, we can see some growth after radiation just due to irritation of the tumor by the radiation. So if we did a scan in a given patient like 5 days after we finished radiation, oftentimes things would be larger. And that's one of the reasons we don't scan that early. The other factor is that a lot of tumors will remain controlled even if we can see them on a scan after they've been radiated. Because what we're seeing on the scan may not be viable tumor anymore. It could be dead cells or cells that are non-functional, or there could be, radiation-induced changes that are mimicking what the tumor used to look like. So after radiation, scan interpretation is tricky, and it does require a lot of thought and expertise and a team effort to try to interpret some of these scans, because one of the most classic things that happens is that we do SRS or SRT for a patient, and then a year later, things are larger. And we're trying to delineate, is this tumor growth? Is this a late radiation-related enlargement called radiation necrosis? And these are difficult to delineate. And as a result, it's the type of thing where, now that reports are immediately accessible to patients, that's wonderful in many ways, but it also can be, problematic for some patients, because they'll read enlargement of this site in a given part of the brain. And I think the immediate conclusion that some patients make is that the tumor's growing, when in reality, that may not be the case a lot.
So it's really important to talk to your oncologist, your radiation oncologist, about what your particular results mean. And it sounds like over time, it may vary in what you're seeing. When you say controlled, you're meaning that there's not growth. Am I correct?
That's right.
Okay. Okay. So it isn't necessarily an expectation that your scan needs to show shrinkage and then complete disappearance of the tumors in order to indicate that you've had success with radiation.
That is entirely true.
Okay. I think that's an expectation we see a lot with those in the breast cancer or brain met community, is expecting that those tumors will completely disappear. And when they don't, it can be confusing.